Good evening, everybody. This is Judy Butler. I am one of the faculty at Frontier Nursing University. I teach in the clinical faculty for the DNP program. I've also been a midwife for almost 20 years, 10 years, the last 10 years at the Birth Center here in Tucson, Arizona, founded by Catherine Schrag, another one of our faculty. And today I held a Right Care Cafe at our birth center, and we included medical assistants, front office staff, doctors, midwives. It was a very multidisciplinary group, really had some great conversation. And so we're just going to move down the line tonight and just introduce everyone, and then we'll get started on our conversation, which is right care as it relates to cost. So Lana, you're next on my left. Do you want to go ahead?
Sure. My name is Lana Burnett. I am representing a small group of military medical professionals from Fort Sam Houston, Texas. We are having discussions tonight about overutilization and underutilization and how it relates to our control of costs at our military treatment facilities. But we will be hanging around a little bit to hear what the larger group has to say.
Great, and thank you. Kitty, do you... Oh, I think we're going to Diana. Go ahead, Diana.
Hi, it's not normally a part of this. And we're going to talk about the cost of healthcare. Say hi. You're just going to be in that Tucson, Arizona. Nobody wants to.
Oh, they're all leaving.
Who are they?
The youth group. Of
Diana, you want to introduce yourself, or do you want to go to Kitty?
We'll go to Kitty.
Kitty, want to introduce everybody there?
Sure. My name is Kitty Ernst, and I'm the Mary Breckerman Chair of Midwifery at Frontier Nursing University. And with me today are two of my oldest and best friends, the two principal investigators for the National Birth Center study that was published in the New England Journal of Medicine. First time a midwife published in the New England Journal of Medicine. We are all nurse midwives, have been in practice and been involved in research and promoting the growth of midwifery in the United States. And I'd like to first go to Judith Rooks, who's on my right, who is, and she will tell you who she is.
I'm actually not in practice, haven't been in practice for a long time, but I'm an epidemiologist, and I've done a lot of research on maternity care and outcomes. And I was just coming to visit Kitty. Actually, I live in Portland, Oregon. I came here to visit Kitty, and so here I am.
And on my left is the third member of that team for the National Birth Center study, Susan Stapleton.
Yes.
And she will tell you all about herself.
Well, maybe not. It's a long story.
All right.
I can't.
Susan, can you turn that camera a little bit so we can see you?
Yeah, I can't hear you. I can't really lean far enough to make that happen. So, can you see the top of my head?
Yes.
No, wait a minute.
What are you doing?
Scoot over this way a little bit, Kitty.
She's going to get up back. All right, now move it.
So I'm Susan Stapleton. I'm nurse midwife, also no longer in practice. I'm doing research primarily that involved with the American Association of Birth Centers, doing the Strong Start project, and now I'm working on some other research for AABC.
Okay.
Well, great. Thank you, everybody. So I think that the program here is that we're just going to talk a little bit about the cost of healthcare, how it has been inhibitive or an issue for us in our professional and or personal lives, and hopefully come up with some possible things that we think might be some solutions. So who would like, I know, Lana, you're going to be breaking off. Do you want to start us off?
Sure. So I can come kind of from a medical standpoint in the military. It's kind of interesting that we have a different angle on what right care looks like. So our primary mission is medical readiness in the military. Employed, or they are back in training environments. So that's a challenge because we have patients in two separate areas. We've had some success stories through our health initiatives that have helped us contain some costs. For example, managing primary care conditions such as low back pain, decreasing the number of MRIs that are ordered for patients because it just doesn't add to the care. But there are more places that we need to tackle the cost of healthcare and military medicine. So we need to have more brainstorming sessions like this to determine how we can do that.
And Lana, who do you have there with you?
So I have a med surgical nurse with me and then a medical logistics professional. Who's have a non-clinician at the table. They come up with some good ideas.
Great, great. All right. And let's turn to Kitty, Susan, and Judith. What sort of issues have you seen? I mean, let's draw from your wealth of experience. How do you see things have changed in terms of cost, in terms of how we practice women's health, midwifery in specific also, and some thoughts on where we need to go with this?
I want to start.
Is that for us?
That's for, yes.
Oh. I don't know where we need to go with it. Tell me again what you want me to say. I was still thinking about what the military was going to do.
That's okay. You can think about the military too, but I really would love to draw on the three of you. I mean, you have such a wealth of experience and different experiences.
Yes.
And where do you see that? I mean, we know kind of the place that we've gotten stuck in. So what are some of your experiences in that place of cost being an issue? And how do you see, or have you seen ways that we get out of it?
Well, where I see it being an issue is that I'm a great believer in the fact that everything in America moves on the dollar, and you can just forget everything else. Because if you don't deal with cost, you're not going to do anything. We know from research that has been conducted since Mary Breckinridge founded the Frontier Nursing Service and published in 1930 under the Metropolitan Life Insurance Company, that you can improve the care with nurse midwives, particularly public health nurse midwives that pay attention to the environment, the family, and the mother and the new baby. I can't even begin to tell you how much research has been done since then, in hospital and out of hospital. But Blue Cross itself studied the first childbearing center, and they know what they're paying from the hospitals. And they said, you can save up to 60% if you put all healthy women in the birth centers and restrict the acute care hospital, which is really a sick house, and a place for people who are severely ill and injured. If you just put the women that have the problems over there, we could save a bundle. 60% is a pretty big saving. That has borne out to be true straight down the line. But we're not an insurance company like Blue Cross was. And in my years of consultation, I've never been able to have a hospital say to me that they can tell me what the true cost of a birth is in their hospital, because they do too much cost shifting. Just for survival purposes, probably, I don't know. But, and it's a very complex institution, an acute care hospital. And things change according to the demands at the moment, too, so it's hard. All we know is how much they charge. And that's not the same as cost. So if we could get to the bottom of true cost, that might be a first step. I don't know how you do that, unless you have somebody donate some money to do it as a study and get some really smart financial people to look in on it. We'll have to go with the charges. So what was the next question?
So over the years, you've seen that change, and you've seen our costs go up and up and up. And I mean, one of the things that I get frustrated with is we know and have known and have shown and have studied how midwives and nurse practitioners are very efficient and effective. And one of the things that we keep plugging over and over in our DNP program when our students are making their projects is, so education isn't, that doesn't get us the outcomes that we want. That doesn't change behavior. So I would like to ask you, how do you think we change behavior? If it's, we've educated people out the yin yang, we've proven that we provide great care, efficient, effective, equitable, all of the 6 aims. How do you think we get behavior to change? How do we change this paradigm so that we are seeing those women, those low risk women?
Those what?
Low risk. In the birth centers.
How do we change the paradigm for
what?
For having nurse midwives take care of the low risk?
Oh, I don't know. I sat and forgive me if I'm seem a little not with it here, but my hearing aids aren't up to par, I guess. And I'm not over 90 years old, so I've seen this whole progression for over 65 years of what are we doing and why are we doing it? And as the students well know, I say, if you really want to know the root cause of what we're doing, follow the money. So I'm thrilled that you're talking about this cost at all, because I don't think we talk about it enough. And when we talk about cost, we have to separate it from charges. And when we talk about money, we have to talk about the value of the care. I mean, should we be paying for it at all? Is a question we need to ask ourselves. And if we are paying for it, how much and where can we get it get the quality and the value that we want for the price that we need to have it? Now, I think the birth centers have demonstrated that. Up the kazoo and down again. Doing it, you're coming up against some very powerful forces, both in the professional organizations, in the insurance industries. People don't understand what you're talking about. Most people do not understand, well, how is an obstetrician different from a midwife? I mean, I like my obstetrician, so I'll just go to him, even though I'm going to pay a lot more money. How is a midwife different? They're very, very different people. The obstetrician is educated to fix the problems, to cure. His whole thing is to cure people, and he needs to be in the acute care hospital. The midwife's whole education is geared at support the natural process, the natural physiological process. Women have been giving birth for centuries. And so they embrace that and support it and help the mother get rid of all the negative feelings that have float around. Everybody likes to make everything negative anyway. And so we have to first understand there are these two groups, and we have to understand that there are two settings, major settings, and then of course there is always the mother's home. But let's just stay with the birth center for a while, because there's more that goes on in the birth center than just the birth. It's the whole year of pregnancy and preparation and education and parenting and nutrition and how to use the system properly instead of just running to the emergency room for every little thing. All of these things is health education. We're focusing on health and we're focusing on prevention. That kind of thing has an enormous payment return. Nothing except that small start grant that they just did 5 years ago, which is just going to say the same thing that all of our studies have said, that the care is better and it costs less. And it empowers, but the most important thing, it empowers women. Now that really scares everybody, because they're not sure they want women empowered. Oh, I'm not supposed to talk like that. All right.
Well, Judith and Susan, do you have any comments on that? I mean, how do you see from your angles, maybe where we, as I said, I think that Kitty has just said the same thing. I know that in your research, Susan, you found the same thing. Where do we, how do we move this past knowledge? We know for a fact that midwives, nurse practitioners give effective, efficient care, all of those things. How do we move this past knowledge into action?
Well, I think some of it is I'm feeling more optimistic than I have in the past in some ways, because I think the very fact that people are looking at cost maternity care, we've become, the very high intervention care that has become sort of the norm is very expensive, and and we know that it doesn't improve outcomes, and that's really been the result of having a medical model, an obstetrical care model, be the primary providers in our maternity care system. I think, some of the workforce issues that are being faced with shrinking numbers of OBGYNs, if the midwives, if Frontier, for example, can sort of keep up with producing more nurse midwives, then I think some of it will just happen automatically. I'm feeling optimistic that if we're ready, if the midwives are ready to step in, there's a growing recognition that we are one of the solutions to the cost problem.
I think there's more than that, because I think foundations, particularly, and the government should be funding up the kazoo nurse midwifery and nurse practitioner education. They're asking some of the people on the lower end of the scale, which are nurses, income scale, usually the primary care providers in their of finances in their families, and they're from a rural area, and anyway, and we expect them to perform miracles, and enter a graduate program, go into debt when they've got 3 or 4 kids to worry about and whether or not they'll be able to go to college. Why can't we fund more nurse midwives and nurse practitioners and put them out there in the rural areas with a family physician? One family physician could to about 10 of these people. Your specialists are not going to go to the rural area because there aren't enough an obstetrician, for example, there's not enough births out there for them to earn a living.
Yeah.
So what you're really talking about is what in IHI, what we talk about is upstream, looking at being before the curve. So we have the problem, how do we go up above it so that we can be ready for the changes? And I think you're absolutely right. Having more nurse midwives and nurse practitioners is one of the answers.
Wait a minute, because, over all these years, every time I sat at a table, national or international, and I would talk about nurse midwifery, I would be pushed aside with the remark, yeah, but they don't know how to produce them. Well, I want to tell you now, Frontier Nursing Service University, we know how to produce them. You give us the money to help those students get their education, and we will produce as many as you want. We and the other universities that are looking to distance education now.
And the funding sources for education and training really have to be reversed so that there's more funding for the lower cost providers, or the providers who generate lower costs within the system because of the kind of care they provide. And right now it's the reverse of that. There's a lot of funding for the high intervention and high cost providers. So that needs to be switched. And, those are policy changes in part that are important.
And Lana, what kind of things have you guys come up with in your chats about this?
Well, I'm the only women's health provider here in the circle, but it was interesting as I was listening to this dialogue, there is a piece of it that belongs in healthcare policy, and most of us are kind of uncomfortable going into that realm because we've never been in DC and lobbying and such, but there's a lot of power issues for many nurse midwives and nurse practitioners, even in their own communities. Even when there's a shortage of providers, there's still a power struggle that might be there. So I think that healthcare policy is something that we have to emphasize. And what kind of support networks do we have for our nurse practitioners and nurse midwives who are trying to get those grassroots movements going in their communities? They need the support to do that.
And I think in Kitty's conversation we have at Frontier, everybody takes a policy course. Everybody takes leadership, because those are things and that we are working on also in the DNP program to form those leaders and to get those people out there, because as it's often said, you know, if you're not at the table, you're on the menu. So we've got to absolutely get it policy. One of the things I also wanted to just bring up was today, one of the things that I just came back from the AABC conference, and someone said to me, I think a lot about this when I started my midwifery program 20 years ago. I joined in with one of the faculty who was doing a program on, you know, what do people think of nurse midwives? What are nurse midwives? And I feel today that we have not budged an iota on what they really understand us to be. So one of the thoughts that came out at the AABC conference was, what do you go to the hospital for? And this comes back to what Kitty said. You go there to get fixed. Something's broken, you go there to get fixed. You're sick, you go there to get better. And that really, I used that yesterday when I had a couple come in, and they transferred. She was 20 weeks from in Tucson. She was very interested in the birth center and our philosophy. He was still a little nervous, wanted to deliver at the hospital, but wanted to come to us. So that, you know, they're making this transition into midwifery care. And I used that comment with him after I did all the education, you know, and what our certifications are and, you know, all the safety measures that we have. I said, so what do you go to the hospital for if you need to? And he thought about it for a while, and he said, well, if I'm sick or I broke my leg or whatever. And I said, she's not broken. So my question to you is, as we have a lot of this research and we keep putting out this research that shows the same thing over and over and over, I'm wondering if we can really put our heads around, so what is it we need to show? Is it the stories that we need to tell? What is it we need to do? Because I feel like we're banging our head against the wall. You know, like we keep saying, here's the research, here's the research, here's the research. What is the other piece? What is that magic sauce that we need to shift this tide? So I guess I challenge both of you, Lana and Susan, Judith, and Kitty. And then we do have a question. So tell me.
Okay, so I can speak on just from a healthcare quality standpoint. What have we learned in healthcare quality? We cannot get anywhere without physician involvement. And so maybe that is our solution, especially to the power struggle, is to find the physicians that are seeing what we're seeing, that are seeing the need, that are seeing the benefits of the healthcare cost, and get those physicians on board and spread the wealth there. And then take those success stories and spread them to other communities. The other thing that might be helpful is some kind of mentorship program, because there's nurse midwives and nurse practitioners that are making this happen in communities around the country. So how can we link them in to help empower other medical professionals? What are they doing that has made it happen? I don't think we have a centralized resource for that. So maybe that's something that they could look at in some of these grassroots organizations specific to women's health.
Some of it, I think, is really just exposure. And like you said, Lana, telling the stories and showing the successful models and how they're working. And, you know, starting with people who are easy to sell, and building from there, because the more exposure there is to nurse midwives, to nurse practitioners on the part of both clients, you know, consumers, and providers, physician providers, then, you know, that exposure will be this kind of spread. And I think that's really important. So I like the idea of telling stories about successful models.
I think we also don't forget that one of the best ways to market our product is to have our mothers and fathers market for us. They need to tell their stories. The story that was just told by a mother whose child had cancer and was cared for by the nurses, it was the most beautiful message that she put on her Facebook page about the nursing care. It would just everybody dream of what you would want in nursing care. That's good for not only for the nurses but for the profession. And I think there's a little girl on, an African-American girl who was asked on a video that was done years ago when we first started the birth center. Yeah. And they said to her, well, what did the birth center do for you? You know, you were what, 16 when you came here and had your baby? And she said, The birth center was a place that empowered me. When I learned about giving birth and the midwives stayed with me and told me I could do it, and I did it, I thought, I have given life. I can do anything. I'm going to go back to school. I'm going to raise this baby. I'm going to get a job. I can do it. That's empowerment. And that's the, if we really want to reform healthcare, that's the shift we had to make. Never mind the professionals, all of us, we're servants to the people.
And how would you relate that to cost, Kitty? How would you tie that empowering the patients into cost, Judith and Susan and Lana?
I think that the more they understand and the more they know, the better shopper they become. And women today are shopping. And we have all the evidence in the world that they are looking everywhere for midwives. They don't know where you are. And that's why we mentioned to a few medical centers that have been promoting midwifery and embracing it, you need to change your department from obstetrics and gynecology to midwifery obstetrics and gynecology so the women can find them. It's removing the barriers, identify them and get rid of them.
I think it's interesting how different healthcare costs and healthcare is in other countries, where they have single payer. You know, medicine in this country, healthcare in this country is not organized to provide
Comprehensive
care. And when we get national or state health care, it will solve all these problems, because cost will be, now cost is profit for somebody, or, you know, profit for some people and lots of costs for other people. We need to have all the other countries that have better outcomes with less money have single payer health care. And we're never going to solve all these problems until we get single payer health care.
They all also have primary maternity care provided by nurse midwives or midwives.
And Lana, as a system that uses, you have a single payer system in the military. I mean, your military is, everybody's covered. How can you address that at all? Do you see any differences when women are, they automatically, your population automatically has coverage?
Right. So first of all, we have a capitated model. So the service members and their families that are assigned to the medical facilities, we have a pot of money that's given to us per patient that we care for inside our own walls. And so it's up to us to manage that money. Of course, there's ways to request extra monies for certain things or initiatives or programs that we call special programs. There's additional funding that comes for that, but we're expected to manage that money. That's why the population health matters so much for the military, because we can only afford to see patients about 6 visits per year. So we have to make sure that, you know, for the patients who need more visits because they have chronic medical problems, our other healthy patients are making up for that cost. So that's what it looks like on the outside, on the inside of our walls. But we also have patients who are sent to the network. That's an entirely different pot of money that that we don't see necessarily. That's seen up at the Department of Health Services. So that's way above our control, really. But we have to be cognizant of what we're spending, and we don't either right now. We don't have a birth center option inside our facilities, but we do have midwifery care at almost all of the military treatment facilities. So we have the opportunity to have an impact within our walls just by providing the right care, so that to advocate more for low-risk women to have low intervention care, intermittent monitoring, that sort of thing, and bringing in things like pain interventions that are lower risk options for them.
Do you see as an organization that you're more aware? Have you worked on the outside, not military?
Oh yes, yeah.
So my question is, do you see a difference in belonging to an institution that feels like they have a certain pot of money that they have to manage versus maybe not having that? That's the insurance companies. That's a different. Can you sense that?
I think that they're both the same type of evil to a certain degree, because on the civilian side of the house, you still had to worry about rejected claims from insurance companies and trying to resolve those and figure that out. And of course, you were dealing with, you charge this much, that doesn't mean you get that much return. But in the military side of the house, there's a lot of people who don't ever touch the money, so they don't know. And that's a challenge that I think has gotten better. We've gotten better about bringing the clinicians into the business conversations. So I would say in the last 10 years, it's gotten better, but it originally was bean counters versus clinicians, and they were enemies. But it's changing, but it's slow.
Which brings us back to Kitty's conversation of we need to know the costs, and nobody can really specify and pin down those costs. Yeah. Any other thoughts, folks? Any thoughts on how we reverse or some of the ways that possibly we are spending money that we don't need to be spending money, or ways that we can save money that we are not using? Some of the solutions more.
I want to make a case for focusing on the care of the mother, because all health care begins with the care of the mother. And Mary Breckinridge said that in 1925. And yet we are not caring for our mothers. I read an article the other day where, what's the matter with America? They don't seem to care that their mothers are dying. What is the matter with us? Maybe we might have some kind of sickness that we need a special hospital for. Honestly, a simple way to do it, a very simple way to do it. You're worried about rural and underserved areas. We are putting nurse midwives and nurse practitioners in those areas. For goodness sakes, forgive the student loans and let them go. Start the ball rolling somewhere.
Agreed. I think you're preaching to the choir. We believe you. We're here.
Okay. So
No, I do have a question here. We have 3 questions actually. The Midwife Solution, a 2020 vision for improving maternity care in Massachusetts. Has any organization examined the legal aspect of restraint of trade of midwife practices, which appear and disappear in hospitals at the whim of those in power? So that's the first half of it. Has anyone examined the legal aspect of restraint of trade? Does anybody know the answer to that one? And how that would obviously affect finances, as we are the lower cost option? And why is there restraint of trade anyway? What is the whole, I believe you, Kitty, that it is follow the money.
And I think because we don't have a system, all the other countries that have better outcomes with less costs have a system in which all the money and all the patients are all part of the same thing.
That wasn't to you. Lana had to go. So you can keep talking. That was just to Lana.
Oh, we could only see you talking.
Yeah, sorry. No, she had to leave. Yeah, so looking at systems and not looking at individual parts. The conversation, of course, today, even in my multidisciplinary, from the medical assistants at front desk to the physicians, we're all bantering around single payer options and how does that get rid of all that middle layer and save us much cost? You know, all of the multiple layers of administration and what do you call it when you have to check and see if it's okay? Oh gosh, sorry, I just lost the name. You know, all of those layers and layers and layers versus just, okay, pay your $10 co-fee. We don't care how many times you come or what you come for. It's $10. Come and have your care. I think restraint of trade is an issue, and it does restrict us. And I think it does come back down to money. Absolutely.
Oh, sure it does.
Yeah, absolutely.
How does a CEO or president of a managed care organization make $15 million a year salary?
They don't give it to their midwives.
Medicare, a single payer, all of Medicare, taking all of the old people like me, they have a 10% cost on overhead to deliver Medicare. I mean, the evidence is all there. Why
Well,
don't?
and the thing is, we're doing it. I mean, it's not like we even have to reinvent the wheel. We're already doing it. 30% of births are on Medicaid.
Yeah.
All right, let's look at this second question. What are some actionable ways we can move women into places of power right now? That's to you three.
What do you mean by
Like politically.
I think to be making these decisions. So what are some actionable ways we can move women into places of power now?
By places of power, what do you mean? You mean having political power, having power within the medical system, healthcare system? What do you mean?
Caitlin, if you're still here, this comes from Caitlin Haney, one of our students. Let's see if Caitlin will respond to me and answer to that. I'm reading these questions. The third question, we'll wait for her to come back in, but the third question is, this is from Michelle McMahon, another one of our doctoral students. There has been talk about transitioning from a volume to outcome-based reimbursement system. Does anyone know if this is still just a conversation or actually something that will come to fruition? So I think she's talking value versus volume, which we've all been hoping for since we already have our value.
Well, I mean, I don't know the answer actually, but I think it has to, just because the healthcare costs are consuming such a large percent and a growing percent of our GDP. So I think, I don't know what the status of it is actually, but I think it has to happen because we can't afford the healthcare we're currently paying for.
And getting bad outcomes. We have all these costs, and we have higher maternal mortality than all those other countries.
Higher infant mortality.
Higher infant mortality. So we're clearly not getting good outcomes. And I think that has to be acknowledged, and people need to understand that. Putting all that money in is not getting what other countries are getting without all this duplication. We have the opposite of duplication, which is some people not getting any care, and lots of duplication. We need to get socialized medicine.
Well, again, you're speaking to the choir. Let me just ask you here. So coming back to this, we did have an answer. So it was, how do we get people in power? And the kind of follow-up to that was, I think you referred to Kitty's comment when women want midwives, but they can't find them. What do women do to demand midwifery care in their communities? How do we make that happen?
You mean us three?
I think she means on a more general level.
I've been working my whole life to make it happen. I don't know. I think that we have to educate the consumer market more.
Yes.
They have to understand that this is not a contest between obstetricians and midwives. They're two totally different people, and you deserve both. And this country has never felt that you did. That you didn't deserve a midwife, because a doctor after all, he does what's important, which is fix a problem. But what about all this other stuff in having a baby and raising a kid? And most of those guys at that time were men. They'd never had a baby. They were never responsible. So they didn't see it. And we have to educate them. We have to educate, well, I don't know. Sometimes I think it's a waste of time to educate Congress because they follow the money better than any of the rest of us. And we don't have enough money to have them listen to us. So we do the best we can with it. But they're making the laws, and we need to make a lot of noise about the laws that need to be made. I think it's happening. I see it happen. Who are these, the right care people? It's happening. We just need to not stop and keep going.
I think from as far as getting people into power, it also we don't pay nearly enough attention to local elections and regional elections. That's really, you know, we tend to focus more on maybe state and then national, but we can really change the power structure a great deal and more easily and with less money at the local level. So I think paying attention to those elections is really important, and we haven't done that enough.
What elections are you talking about on a local level?
Local, state elections, not national.
Oh, you mean the governors and the, yeah.
Yeah, getting people.
Yeah, because the state. See, we're not really a United States at all.
Oh, yeah,
we're 50 different countries. And we all have different focuses and everything. So that if we individually in every state take on our own country, and never mind the big guns in Washington, they're probably going to play with nuclear war anyway.
Might be too late.
Mhm.
Yeah.
We have one more question here. I think this is from Susan Stone. Make more midwives. The midwives need to be available and accessible. So answering that advocacy and helping legislatures understand the cost savings. Yes, I think we need to, I think obviously we've come to the same thing that we need to make more midwives, but we need to also be educating. Who is it that we're educating? We need to get the word out there to the local people so that they are really standing up for it and coming and finding it themselves. I think we have to remember that we are servants, but we have to empower the people who are going to be around a long time, and that's the mothers and their babies and their families. We've got to empower them with that knowledge that they get to make a choice.
And the fact is, if you educate more midwives and get them out into the communities where there are no midwives and nurse practitioners, they will sort of create their own demand as people get to know them, because it's very appealing care to consumers once they know about it.
Once they experience
So
it.
putting the midwives out there and the nurse practitioners out there is really an important part of it. It can't be exposed to them if they're not around.
Exactly.
It's only just begun.
We have to reach the tipping point.
Yeah.
We're getting there.
Yes.
All right, any other words of wisdom from the three of you on cost of healthcare, midwifery, women's health, nurse practitioners?
We need to do less.
What do you mean? We need to do less.
We need to do less expensive stuff that's making things worse, and we need to do more non-expensive stuff or less expensive stuff that actually makes a difference, which goes back to having more midwives and nurse practitioners as well.
Right.
We need to do this. We need to make people prove to us how this is going to improve the health and care of the mother and how it's going to lower cost. If we had done that with electronic fetal monitors, they would have been trashed a long time ago. All they have done is serve to raise the rate of
Cesarean sections.
No, cesarean sections,
and
but
lawsuits.
even worse than that, lawsuits.
Yeah.
And there you have another whole industry that's grabbing money out of your healthcare industry. It's stupid.
And that's why we're too fragmented.
Yeah.
You know, we need to have a healthcare system that the money, the people, the patients, the providers, we have an overall system instead of lots of little individual systems, each one with its own paperwork, its own costs from. We need to have single payer system.
Yeah, the middle again. Well, I think that Frontier is ready to wrap this up. I thank the three of you so much for joining us and giving us your words of wisdom and your years of experience. We hope that we are moving in the right direction to lower costs of healthcare. Certainly, we know that midwives and nurse practitioners do this. The data is conclusive and continues to be conclusive. So we just have to keep pushing. And as I think, as Kitty said, hopefully we are on the right track. And the fact that these are happening all over the country and people are talking about it, and young people, old people, in the middle people, people on the left, people on the right. It's not just a political discussion, but that everyone is discussing, because as it came out today at the birth center, when we had all these different people, all different education levels, it affects every single person, everybody. So I thank you from Frontier. We are going to sign out, and we will share this with you, and we'll share this with all of our lone friends. And thank you all for your wisdom.
Thank you.
Thank you.
Good night,
Good night.
everybody.